Imagine you have a profession that basically puts you right in the line of fire. Like, let's say you're a beekeeper.
Right, out there with the hives every day.
Exactly. You're working with the hives, and over the course of a year, you suffer a handful of stings. Maybe 5, 10, perhaps 15 times over 12 months. The medical literature tells us that with that specific frequency...
Which is pretty low, all things considered.
Right, low frequency. But with that frequency, your risk of having a massive, potentially fatal allergic reaction is horrifyingly high. It's somewhere around 45%.
Yeah, that number is staggering.
It really is. But if you take that exact same beekeeper and they get stung wildly more often, like more than 200 times a year, essentially getting stung almost every single day, their risk of that fatal allergic reaction just plummets. It drops to absolute zero.
It is, hands down, one of the most stunning immunological paradoxes we have ever documented. I mean, the human body takes a small amount of poison over time and treats it as a deadly system-wide emergency.
Right.
But if you drown the body in that same poison relentlessly, day after day, the immune system simply shrugs. It just builds an impenetrable shield.
Which totally goes against every intuitive thought we have about toxins and damage. You would think the damage is cumulative.
You'd think so, yeah, like a bucket filling up.
Exactly, like a bucket filling up with water until it overflows. But the immune system isn't a bucket, it's a learning engine. And today, for you listening, we are going to look right under the hood of that engine. Welcome to the deep dive.
Glad to be here.
We are embarking on an intricate, microscopic, and quite frankly, life or death exploration into the world of Hymenoptera venom allergy. That is the intense science of bee, wasp, and ant stings.
We are pulling from 3 foundational, highly regarded pieces of medical literature for this analysis. So we have a 2005 diagnostic review by Billow and colleagues. Yeah. A real benchmark. Then a prevention and treatment review from that same year by Bonifazi and team. And then, tying the whole modern era together, there's a massive 2017 systematic review and meta-analysis by Dami and Associates, which was published in the journal Allergy.
So whether you are the person who, abandons your meal and sprints across the yard the second a yellow jacket lands on the patio table.
Which is a lot of people.
Oh, absolutely. Or if you're just a curious learner trying to decode the human body, we're going to break this all down without getting lost in all the medical jargon. Okay, let's unpack this. We need to start by understanding exactly what is attacking you. Like, what are the culprits and what kind of chemical weapons are they actually packing?
Right, the attackers.
From there, we'll journey into the body to see how the immune system reacts and the hidden traps waiting inside you. We'll look at the chaotic detective work doctors have to do when the tests literally lie to them.
That part is fascinating.
It's wild. And finally, we'll explore the frontline defenses and a futuristic medical hack that can permanently rewrite your immune system.
So, to understand the threat, we really have to look at the taxonomy. The order of insects we are discussing is called Hymenoptera, but we need to narrow our focus specifically to a suborder known as Aculeatae.
Okay, Aculeatae.
Yeah, and this is the group of insects that have evolved a stinger. Within this suborder, there are 3 primary families that are medically relevant to severe human allergies.
Let's categorize these so we can really picture them.
Sure. First is the Apidae family. These are your honeybees, scientifically known as Apis mellifera, and the bumblebees from the genus Bombus. If you picture them, they're generally brown, sometimes with yellow or white bands, but their defining visual characteristic is their hair.
They're fuzzy.
Exactly, they're very fuzzy.
Right, they need that hair to collect pollen. They are the fuzzy, industrious ones that we generally want flying around our gardens.
Yeah, we like them. Then we have the Vespidae family. These are the wasps, the yellow jackets, and the hornets. Visually, they are the stark opposite of the bees. They're almost entirely hairless.
Smooth and mean looking.
Very smooth, they have hard exoskeletons, and they typically feature these very aggressive, high-contrast black and yellow stripes.
And the sources actually mention that allergists need you to pay attention to their body shape if you get stung, which honestly sounds impossible to do when you're in agonizing pain.
It is incredibly difficult, but it completely changes the diagnostic pathway. Within the Vespidae family, allergists divide them into subfamilies. You have Vespinae and Polistinae.
Okay, what's the difference?
The differentiation is geometric. If you look at the junction where their thorax, so that's the middle section with the wings and legs, meets the abdomen, which is the back section with the stinger.
Right.
Well, Vespinae have a flat, truncated junction. It looks like it was chopped off bluntly. Polistinae, which include the common paper wasps, have a much more tapered oval shape at that junction.
I mean, I am just trying to imagine getting stung by a wasp and having the presence of mind to analyze its waistline geometry. Like, well, doctor, I'm going into shock, but I can confidently confirm it had a wonderfully tapered oval thorax junction.
It sounds totally absurd, I know.
Yeah.
But as we'll see later when we get to the blood testing, knowing the geometry can solve massive medical mysteries.
Wow.
We also have a third family, Formicidae, which encompasses the ants. While most ants are harmless, the imported fire ants, specifically in the Solenopsis genus, they are a major trigger for severe allergic responses, especially in parts of the Americas.
Okay, so we have our lineup. We've got the fuzzy bees, the smooth wasps, and the stinging ants. But they don't deliver their venom in the same way, right? The payload delivery systems are drastically different.
Let's look at the honeybee first.
Right, so a honeybee sting is an absolute biological commitment. The honeybee possesses a barbed stinger. When it strikes a human or, any mammal with thick skin, those barbs catch.
Like a fishhook.
Exactly like a fishhook. So when the bee tries to fly away, it cannot pull the stinger out. It ends up tearing the stinger, the venom sac, and part of its own digestive tract completely out of its body. The bee will die shortly after.
It's literally a kamikaze mission. It is. But the result of leaving that entire apparatus behind is a massive, massive delivery of venom. A honeybee leaves between 50 to 140 micrograms of venom protein right in your skin.
And what about bumblebees?
Bumblebees, which generally don't leave their stingers behind, deliver a much smaller payload, about 10 to 31 micrograms.
I mean, 140 micrograms from a honeybee feels like a huge amount compared to what the wasps do.
Oh, it is. Wasps and yellow jackets, the vespids, deliver a remarkably tiny payload. We are talking about 1.7 to 17 micrograms per sting.
That's practically nothing.
It's a tiny fraction of what the honeybee drops. However, the wasp has a smooth stinger. It slides in and out easily. Therefore, a single wasp can strike you repeatedly in a matter of seconds, pumping multiple tiny payloads into your tissue while surviving, to fly away and do it again.
So the bee drops a massive bomb once, and the wasp is doing rapid-fire, tiny surgical strikes. But let's talk about what's actually in those payloads. Because it's not just a generic poison, right? The sources break down the chemical cocktail, and it's incredibly sophisticated.
Venom is an evolutionary masterpiece of offensive chemistry. It is specifically designed to cause intense pain and localized tissue destruction. In clinical terms, we are looking at major allergens, which are primarily glycoproteins.
Okay.
Molecular biologists measure the size of these proteins in a unit called kilodaltons, or KDA. Most venom allergens sit somewhere between 10 and 50 kilona.
To give the listener some context, how big is that in the grand scheme of the body?
Very, very small.
Yeah.
Small enough to easily slip between your cells and rapidly disperse through your tissues. If we break down honeybee venom, the most critical enzyme is called phospholipase A2. It makes up roughly 12 to 15% of the venom's dry weight.
Phospholipase. Okay, anything ending in A's is usually an enzyme that breaks something apart. What is this breaking apart?
Your cell membranes. The outer protective layer of human cells is made of phospholipids fatty acids. Phospholipase A2 functions like a pair of rapid-fire molecular scissors.
Molecular scissors. That sounds bad.
It physically snips the fatty acids right off your cell membranes. It is a cytotoxin. It destroys the structural integrity of your cells, causing them to rupture, spill their contents, and basically die.
So the second the venom is in my skin, these molecular scissors are just clear-cutting my cell wall.
Yes.
Yeah.
But that's just the vanguard. 50% of the dry weight of bee venom is a tiny peptide called melittin.
Melittin, okay.
Melittin is minuscule, only 2.9 kilodaltons. And it has a very specific job. It forces itself into the cell membrane and aggregates to form a literal hole, a pore.
Wait, so if I'm understanding this right, the venom isn't just one poison. It's a highly evolved chemical cocktail where the bartender threw in tissue-destroying enzymes and cell-bursting peptides.
Yeah.
It's punching holes in the cells.
Exactly. It punches holes, which destabilizes the cell and allows the phospholipase A2 to get inside and do even more damage. They work synergistically.
That's brutal.
What's curious, though, is that despite melittin making up half the venom, the BioLaw paper notes that only about 28% of allergic patients actually possess antibodies that react to it. Yeah, it's the phospholipase A2 that the human immune system usually flags as the major catastrophic threat.
Okay, so the honeybee cocktail is basically scissors and hole punchers destroying the tissue. What about the wasp? They have a different recipe.
The vespids rely on a slightly different version of the scissors, phospholipase A1, along with a protein called antigen 5, which we still don't fully understand the biological function of. But their most diabolical ingredient is an enzyme called hyaluronidase.
I am pausing here because anyone who follows skincare might recognize that root word, hyaluronic acid. It's the stuff in serums that makes your skin look plump and youthful.
The connection is direct. Hyaluronic acid is essentially the biological mortar that holds the bricks of your connective tissue together. It creates structure.
Okay.
Hyaluronidase is an enzyme that dissolves that mortar. When the wasp injects this, it literally melts the connective tissue between your cells.
Why would a wasp want to melt the mortar between my cells?
To create a spreading factor. By dissolving the structural barriers in your skin, the wasp clears a microscopic highway. It allows all the other toxic components, the phospholipase and the antigen 5, to travel deeper and faster into your bloodstream and surrounding tissues.
It's melting the roads so the invading army can march faster. That is terrifyingly efficient.
It really is.
But this chemistry is only the opening act. The venom is in the tissue, the cells are being cut open, the mortar is melting. Now, the human body has to respond. The sources categorize this response, moving us from the local sting site to the body's systemic battlefield.
Right. The clinical presentation of a sting varies wildly among the population. The baseline, what we call a normal local reaction, is what most people experience.
Just a standard bug bite.
Exactly. You get stung, there is immediate sharp pain, a red welt forms, there is some minor swelling, and within a few hours to a day, it resolves. That is simply your body cleaning up the localized cellular destruction we just described.
It hurts, but it's contained. What is the next level up?
The next level is the large local reaction. Clinically, this is defined as swelling that exceeds a diameter of 10 centimeters, which is about 4 inches, and continues to persist for more than 24 hours, sometimes taking days to resolve.
Wow, over 4 inches.
The swelling can be massive. If you are stung on the hand, your entire forearm might swell up. It can even blister.
And according to the epidemiological data in these papers, this isn't rare. Up to 26.4% of the general population will experience these large local reactions. That means 1 in 4 people listening right now has an immune system that will overreact to this extent.
It is highly uncomfortable, but crucially, a large local reaction is generally not life-threatening unless the sting occurs inside the mouth or throat where the swelling could physically obstruct the airway.
Right.
The true danger lies in systemic reactions, where the chaos escapes the local sting site and involves the entire body.
The sources outline 2 types of systemic reactions, toxic and anaphylactic. What is the distinction? Because both sound awful.
A systemic toxic reaction is a matter of sheer volume. This occurs when an individual suffers dozens, hundreds, or even thousands of stings simultaneously.
Like stepping in a nest.
Exactly. Perhaps they disturbed a massive hornet nest. There is so much physical venom, so much phospholipase and melittin in the bloodstream that the chemicals themselves poison the organs, leading to breakdown of muscle tissue, kidney failure, and shock. The body is simply overwhelmed by the toxin.
It's a dosage issue. Anyone would suffer a toxic reaction if they were stung enough times.
Correct. Systemic anaphylaxis, however, is completely different. It is an error in the host's immune system. It can be triggered by a single, solitary sting. The tiny microgram payload of venom enters the body, and the immune system misinterprets it as an existential, system-wide threat.
The numbers for systemic anaphylaxis are sobering. The sources state it occurs in 0.3% to 7.5% of the population. Even at the lower end, that's millions of people whose bodies will effectively try to shut down from one bug bite.
To understand why the body shuts down, we have to look at the immune system's first responders. Scattered throughout all of your connective tissues, especially in your skin, lungs, and gut, are cells called mast cells.
I'm going to need a strong visual for mast cells because they seem to be the main characters in this allergic drama.
Think of mast cells as overzealous, heavily armed security guards stationed at all the borders of your body. Inside each mast cell are thousands of tiny granules, which are essentially tear gas canisters filled with inflammatory chemicals, the most prominent being histamine.
Okay, so the guards are just standing there holding the tear gas. How do they know when to throw it?
They are holding on to specific antibodies called IgE immunoglobulin E. These IgE antibodies are like wanted posters.
Wanted posters.
Yeah. In an allergic person, the immune system has previously encountered the bee venom, decided it was a massive threat, and printed millions of these IgE wanted posters with the exact shape of the venom protein on them. It handed these posters to the mast cell security guards.
So when the person gets stung a second time, the venom enters the skin. The mast cell guard looks at the venom, looks at the IgE wanted poster, sees a perfect match, and panics.
Exactly. The binding of the venom to the IgE antibody sends a signal into the mast cell. calcium floods into the cell, and the guard pulls the pin on all the tear gas.
Oh, man.
The mast cell undergoes degranulation, dumping all of its histamine and other inflammatory mediators directly into the surrounding tissue and bloodstream.
And what does that systemic flood of histamine actually do to the body? Why is it fatal?
Histamine has two profound, rapid effects on the cardiovascular and respiratory systems. First, it causes vasodilation. It forces your blood vessels to rapidly widen and relax.
Okay.
Imagine the pipes in your house suddenly expanding to 3 times their normal size. The water pressure would instantly drop to a trickle. The same happens to your blood pressure. It plummets, depriving your brain and heart of oxygen.
That's the shock.
Yes. Second, histamine causes smooth muscle constriction, particularly in the bronchioles of your lungs. Your airways squeeze shut.
So your blood pressure has crashed, and you simultaneously cannot pull air into your lungs.
That combination leads to cardiovascular collapse and, if uninterrupted, cardiac arrest.
Which brings us back to that terrifying beekeeper paradox we opened with. The 45% of infrequent beekeepers having these massive anaphylactic reactions versus the 0% in the highly stung group. Wait, so getting stung 5 times a year is highly dangerous, but getting stung 200 times makes you immune. That's like microdosing poison to build a shield. But why does the time interval between stings matter so much to the immune system?
If we connect this to the bigger picture, it's all about how the immune system assesses long-term threats. When you are stung infrequently, say, twice a month, the immune system sees the venom, notes the tissue damage caused by the molecular scissors, and thinks, this is a rare, highly destructive invader. Keep the IgE wanted posters fresh, keep the guards on high alert. Next time it shows up, we launch the nuclear option.
The body assumes the rare threat is an anomaly that must be annihilated instantly.
But if you're stung 200 times a year, the environment changes. The immune system is constantly seeing the venom. It eventually realizes that if it launches a massive histamine attack every single day, the inflammation will destroy the host faster than the venom ever could.
The security guards would burn the city down just trying to protect it.
Precisely. So the immune system executes a profound shift. It stops making the IgE-wanted posters. Instead, it starts producing a different class of antibody called IgG4. These are blocking antibodies.
How does a blocking antibody work?
Think of IgG4 as a swarm of diplomats. They recognize the venom, but they don't have the mechanism to trigger the mast cells. When the venom enters the body, the swarm of IG4 diplomats surround it and cover it up before the venom can ever reach the mast cell security guards.
Wow. The threat is neutralized silently.
Furthermore, the immune system generates regulatory T cells, the peacekeepers, that actively suppress the mast cells from firing. The sheer frequency of the venom forces the body to learn tolerance.
That is an incredible biological adaptation. But for the average person who isn't getting stung every day, they are relying on their baseline immune system. And the literature highlights several hidden risk factors that make that baseline much more dangerous. If you fall into that 0.3 to 7.5% of the allergic population, certain things increase your chance of a fatal outcome.
Age is a significant factor. Children generally have a much more favorable prognosis.
Really?
Yeah, in the pediatric population, 60% of systemic reactions are limited to the skin widespread hives and flushing, but no airway or blood pressure issues. In adults, however, 70% of systemic reactions involve those life-threatening respiratory or cardiovascular symptoms. The fatality rate climbs sharply in the elderly.
And the sources point out that underlying cardiovascular disease is a huge vulnerability. If your heart is already struggling, it simply cannot survive the massive drop in blood pressure that the histamine triggers.
There is also the issue of the time interval between stings. If you are stung and then stung again just a few weeks or a couple of months later, your risk of a severe reaction spikes.
Because the immune system just printed all those IgE-wanted posters and the ink is still wet, the guards are on maximum alert.
Exactly. But the most insidious hidden risk factor documented in these reviews is a condition called mastocytosis, which can be flagged by elevated baseline serum tryptase levels.
I want to break this down slowly because it's a terrifying concept. We established that mast cells are the security guards holding the histamine tear gas. What is mastocytosis?
Mastocytosis is a rare disorder where the body produces an abnormal, massive number of mast cells. The patient has an unusually high whole-body mast cell load. Instead of having a normal contingent of security guards scattered throughout their tissues, they have an entire army of them, packed tightly into the skin, the gut, and the bone marrow.
Oh, man. So if a normal allergic person gets stung, a certain number of guards throw their tear gas, and you get anaphylaxis. If someone with mastocytosis gets stung,
The entire army throws the tear gas at once. The histamine release is exponentially larger. The reaction is extraordinarily rapid, violent, and very frequently fatal. The blood pressure crash is almost immediate.
how would a person even know they have this? Do they just have to wait to get stung to find out they have this massive internal army?
Not necessarily. Allergists can test for this hidden danger by measuring something called baseline serum tryptase.
What is tryptase?
Inside those mast cell granules, alongside the histamine, is an enzyme called tryptase. Think of it as the exhaust fume of the tear gas canister. It's always released when the mast cell detonates. However, even when there is no allergic reaction happening, mast cells naturally leak a tiny, microscopic amount of tryptase into the blood just by existing.
Okay, I think I see where this is going. If you have a normal number of guards, there is a normal low level of exhaust fumes in the blood.
Correct. If a doctor draws your blood on a completely normal day, when you aren't having an allergic reaction, and they find that your baseline level of tryptase is abnormally high, it's a glaring red flag. It implies that you have a dangerously high number of mast cells in your body, simply leaking that exhaust. You have a powder keg waiting for a spark.
That brings a level of anxiety to a simple picnic that I wasn't prepared for. Knowing these hidden risks, it becomes incredibly clear why doctors can't just guess at a diagnosis. If you come into the clinic after a severe reaction, the doctor has to figure out exactly what stung you and exactly what your immune system is capable of doing next. Which brings us to the diagnostic process, the detective work.
Diagnosing a venom allergy is a meticulous, stepwise investigation. It always begins with the clinical history. The doctor will ask, what did the insect look like? Where were you? Did it leave a stinger?
Right.
But, as we discussed earlier with the truncated versus oval waistlines, humans are notoriously unreliable eyewitnesses, especially when in pain and panic.
It was yellow, it buzzed, and I hated it. That's about all the detail I'd be able to give.
Exactly. Therefore, the allergist must rely on biological testing to find the truth. The gold standard begins with skin testing. They start with the skin prick test.
How does that work?
They place a microscopic drop of highly diluted, purified insect venom on the surface of your arm and use a tiny lancet to gently prick the top layer of the skin through the drop. They wait 15 minutes to see if a wheal of raised minchet. A raised, itchy bump and a flare of redness develops.
And if nothing happens, does that mean you aren't allergic?
No, the prick test is very safe, but not always sensitive enough to catch a lower-level allergy. If the prick test is negative, they move to the intradermal test. This is much more sensitive.
Okay.
Using a very fine needle, they inject a tiny volume of venom directly under the top layer of the skin, creating a small blister. They use increasing concentrations, usually starting at 0.01 micrograms per milliliter and going up to 1.0 microgram per milliliter.
They are actively trying to trigger those localized mast cell guards in your arm to prove they have the wanted posters. But there is a massive caveat in the Bilo paper about the timing of these skin tests, the refractory period.
This is a critical clinical trap. You cannot perform these skin tests immediately after the patient has suffered a severe systemic reaction in the wild. You must wait at least 2 weeks, and sometimes up to 6 or 8 weeks, before testing them.
Why? If they just almost died from a bee sting, shouldn't their arm light up like a Christmas tree if you inject bee venom into it the next day?
You would think so, but you have to remember what happened during that massive reaction. The mast cell army detonated. They released all their histamine. They dumped their granules. It takes time for the human body to manufacture more histamine and synthesize new IgE antibodies to rearm those cells.
Oh, they're completely out of ammunition.
Exactly. If you test a highly allergic patient 2 days after anaphylaxis, the test will likely come back completely negative. The venom is in the skin, but the guards have no tear gas left to throw. It is a false negative. The allergist must respect the refractory period to give the immune system time to reset and reload.
So they wait a month, they do the skin tests, and alongside that, they draw blood for in vitro testing. They are looking for those specific IgE antibodies floating in the blood serum. But this is where the detective work hits a wall that the sources spend a lot of time on. The mystery of cross-reactivity versus double sensitization.
This is perhaps the greatest headache in venom allergy diagnostics. A patient comes into the clinic, they don't know what stung them, the doctor does the skin tests and the blood work. The results come back, and they are strongly positive for honeybee venom, AND, strongly positive for yellow jacket wasp venom.
The doctor looks at that and has to ask, is this person truly allergic to both insects, or is the test lying to me?
It happens frequently. And to understand the lie, we have to go back to the chemistry we discussed earlier. Remember the enzyme hyaluronidase? The mortar-melting enzyme?
Yes, the spreading factor.
Both bees and wasps use hyaluronidase in their venom cocktails. Biologically, the amino acid sequence of the hyaluronidase in a bee is about 50% identical to the enzyme in a wasp. They share half of their structural identity.
Okay, I'm picturing the immune system's wanted posters again. The IgE antibody isn't taking a picture of the entire insect. It's taking a picture of a very specific microscopic shape on the surface of the venom protein.
Correct. Those shapes are called epitopes. And because the bee and wasp enzymes are 50% identical, they share some of the exact same surface shapes. So the patient might only be allergic to wasp venom. Their body makes antibodies against the wasp shapes. But when the doctor's blood test exposes that blood to bee venom, the antibodies see those shared shapes, bind to them, and trigger a positive result.
The antibody is like facial recognition software that's confusing two different suspects because they have the exact same nose.
That's a perfect way to conceptualize it. But the illusion gets even deeper. The antibodies aren't just looking at the protein structure itself. Many of these venom proteins are glycoproteins. They have complex sugar molecules attached to their surfaces. We call these carbohydrate epitopes.
Sugar molecules on the venom.
Yes. And it turns out these exact same structural sugar molecules are found all over the plant kingdom. They are heavily present on plant pollen.
Wait, are you saying what I think you're saying?
A patient might have severe seasonal hay fever. They are highly allergic to tree pollen or grass pollen. Their immune system generates massive amounts of IgE antibodies specifically targeted at the carbohydrate shapes on that pollen.
Wow.
Then they get a blood test for a wasp allergy. The blood test sees those pollen antibodies binding to the exact same sugar shapes on the wasp venom in the test tube and registers a massive, glowing positive result.
But the patient isn't allergic to the dangerous cell-destroying protein part of the wasp venom at all. They are just reacting to the sugar coating because it looks like pollen. That is an unbelievable biological false positive.
We call it cross-reactivity. It's an immunological illusion. So the doctor is staring at a double positive result and has to solve the mystery. Is it double sensitization, meaning the patient possesses independent antibodies specifically designed for the unique, dangerous parts of both the bee and the wasp? Or is it cross-reactivity, the facial recognition software getting confused by shared shapes or pollen sugars?
How do they actually solve that? They can't just flip a coin. The patient's life depends on the right treatment.
They use a highly specialized laboratory procedure called RAST inhibition testing. RAST stands for radioalloresorbent test.
Walk me through how RAST inhibition breaks the illusion.
Let's say the patient is positive for both bee and wasp. The lab takes the patient's blood serum, which contains all of their circulating antibodies. They mix that serum in a test tube with a massive, overwhelming concentration of bee venom. They let it sit.
What does that do?
If the patient's positive wasp result was just an illusion caused by shared shapes, then that massive flood of bee venom will bind to every single one of those confused antibodies. The bee venom acts like a molecular sponge, soaking up all the cross-reactive antibodies.
It traps all the facial recognition software that's looking for the shared nose.
Exactly. Then the lab takes that sponge serum, which has had all the cross-reactive antibodies neutralized, and they test it against the wasp venom.
Okay.
If there is still a strong positive reaction, it means there are unique antibodies floating in the blood that completely ignored the bee venom sponge. They are specifically designed only for the wasp. That proves true double sensitization. The patient is allergic to both.
And if the reaction to the wasp disappears?
It means it was just cross-reactivity. The bee venom sponge soaked up everything, proving the wasp positive was an illusion. The patient only needs to be treated for the bee allergy.
That is brilliant deductive science at the microscopic level. But reading through the diagnostic section of the sources, there is one test mention that made me stop dead in my tracks: the live sting challenge.
Yes, it is exactly what the name implies.
A live insect challenge. They literally bring a live wasp into the hospital room and let it sting you. That sounds like a medical medieval trial. Why on earth would they do that? We just spent the last half hour explaining how one sting can crash blood pressure, close the airway, and cause cardiac arrest.
This raises an important question. It highlights a fundamental limitation of lab tests. We can prick the skin. We can find the IgE antibodies in the blood. We can use the sponge to prove they are specific. But none of those lab tests can definitively predict how the entire complex, interconnected human body will actually respond in the real world.
Right, a test tube isn't a person.
Exactly.
Oh.
A high level of antibodies in a test tube might translate to a few hives, or it might translate to instant cardiovascular collapse. The only way to truly know how the system reacts is to challenge the system.
I am still struggling with the risk-to-reward ratio here.
Which is why the clinical guidelines are incredibly strict. The live sting challenge is absolutely contraindicated, meaning it should never be done for diagnostic purposes in untreated patients. You do not trigger a suspected mast cell army just to see if they'll destroy the host. It is too dangerous.
Okay, so if they don't use it to diagnose the allergy, when do they use it?
They use it to prove that a medical cure has worked. It is used in highly controlled hospital settings, usually with an intensive care unit on standby, to test the efficacy of venom immunotherapy in high-risk patients.
Oh, I see.
If a patient is a beekeeper or has mastocytosis, and they have undergone years of immune reprogramming therapy, the doctor needs to be 100% certain the treatment holds up before sending them back out into a high-risk environment. A tolerated live sting challenge is the ultimate, undeniable proof of clinical protection. It is the final exam of the immune system.
Okay, that makes clinical sense. You need to know the shield works before you send the soldier back into the field. But this brings us to the immediate reality of an attack. Diagnosing the allergy is one thing. Surviving the actual sting is another. Let's move to the frontline defense, the emergency response.
The Bonifazi review outlines the prevention strategies, which sound like common sense, but are statistically vital for allergic individuals. Avoid walking barefoot in grass. Do not cut hedges or pick fallen fruit where wasps might be feeding.
Makes sense.
Avoid wearing bright floral clothing or heavily scented perfumes that might confuse a foraging bee.
But bugs fly, and accidents happen. What is the protocol the absolute second an allergic person gets stung and feels their throat starting to tighten?
There is only one acceptable frontline defense for systemic anaphylaxis: epinephrine, commonly known as adrenaline. It must be administered immediately via an intramuscular injection, almost always into the vastus lateralis muscle of the outer thigh.
The sources make a very aggressive point about this. There is a common misconception among people that if they get stung, they can just chew up a Benadryl and antihistamine or maybe take an oral corticosteroid and they'll be fine.
It is a deadly misconception. The literature explicitly states that H1 antihistamines and corticosteroids have their place. They're excellent for managing the mild secondary symptoms like the itchy hives and the localized swelling.
Right.
But they take far too long to work. And more importantly, they do not target the critical organ systems that are actively failing. They should never, under any circumstances, replace or delay the use of epinephrine in a systemic reaction.
Let's unpack the pharmacology here. Why is adrenaline the magic bullet? What is it doing that an antihistamine cannot?
We established earlier that anaphylaxis causes massive vasodilation, the blood vessels widen and blood pressure crashes, and bronchoconstriction, the airways clamp shut. Adrenaline is a powerful sympathomimetic amine. It directly mimics the effects of your sympathetic nervous system, your fight-or-flight response.
It's flipping the master survival switch.
Precisely. Adrenaline binds to two different types of receptors simultaneously. First, it hits the alpha-adrenergic receptors located on the walls of your blood vessels. When these receptors are stimulated, they force the smooth muscle in the blood vessels to violently constrict.
It's clamping those expanded pipes back down to their normal size.
Yes. This creates instant hemodynamic recovery. By tightening the vessels, it rapidly forces the blood pressure back up, ensuring the brain and the heart continue to receive oxygenated blood.
Wow.
Simultaneously, the adrenaline binds to the beta-adrenergic receptors located in the lungs. This has the exact opposite physical effect. It forces the smooth muscles around the airways to relax and dilate, throwing the airway back open so the patient can pull oxygen in.
It fixes the blood pressure and opens the lungs at the exact same time. It's a chemical override of the allergic chaos.
And timing is the most critical factor. The Bonifazi paper cites animal models demonstrating the grim reality of delayed administration. If adrenaline is given too late, if the patient waits to see if the reaction gets worse and they reach the nadir, the absolute bottom of the shock cascade, the adrenaline fails to produce hemodynamic recovery.
Even if you give it to them.
Even when the drug is circulating in the blood, the cardiovascular system is too deeply compromised, too far gone to respond to the signal. You must inject immediately.
Which is why allergists prescribe the auto-injectors, the EpiPens. But there is a terrifying complication outlined in the literature regarding a very common daily medication, the beta blocker complication. We touched on this earlier as a hidden risk factor.
Millions of people globally take beta blocker medications to manage high blood pressure, arrhythmias, or to protect the heart after a heart attack. The medication does exactly what its name implies. It sits on the beta-adrenergic receptors and blocks them, keeping the heart rate calm and the blood vessels relaxed.
I am seeing the immediate problem here. You just told me that adrenaline needs to bind to those exact same beta receptors to relax the airways and save the patient's life.
That is the crisis. If a patient taking a beta blocker goes into anaphylactic shock and they inject their EpiPen, the massive dose of adrenaline floods their system but hits a literal chemical wall. The receptors are blocked. The adrenaline cannot bind.
The override switch is broken. What happens to the patient?
They experience what is called refractory hypotension, stubbornly low blood pressure that simply will not rise no matter how many doses of epinephrine you pump into them. They also experience severe unbreakable bronchospasm. The normal life-saving protocol is completely neutralized.
What does an ER doctor do in that scenario? The patient is dying and adrenaline isn't working.
They have to utilize a completely different pharmacological pathway. They administer a drug called glucagon.
Glucagon? Isn't that the hormone involved in blood sugar regulation? Diabetics use it if their blood sugar drops too low.
It is. But glucagon has a very unique secondary property. It has the ability to stimulate the heart muscle and relax the smooth muscles of the airways independently of the beta receptors. It has its own dedicated receptors.
Unbelievable.
It acts as a backdoor key to bypass the beta blockade entirely and force the cardiovascular system to restart.
That is a phenomenal piece of medical improvisation. The body has so many hidden pathways. Let's touch on one more practical piece of frontline defense from the sources, specifically regarding the honeybee stinger.
Okay.
If a bee stings you, the stinger is stuck in your arm. For decades, the common wisdom, the thing everyone was taught in scouting or first aid was, do not pinch the stinger with your fingers or tweezers because you will squeeze the venom sac and pump more poison into yourself. You must find a credit card and gently scrape it off.
The clinical literature actively corrects this myth. The anatomy of the bee stinger is complex. It isn't just a passive needle attached to a sac. It has its own autonomous microscopic muscular valves that continue to actuate and pump venom down the shaft even after it has been torn away from the bee.
It's an automatic pumping station.
Yes. Studies have shown that the method of removal, scraping it with a card versus pinching it with your fingers, makes absolutely no statistical difference in the volume of venom injected. The only metric that matters is time.
Because every fraction of a second that thing is in the skin, those autonomous valves are pumping more phospholipase and melittin into your tissue.
Exactly. Waiting even 10 seconds to dig through your wallet for a credit card results in a significantly larger envenomation than simply pinching it and ripping it out immediately. The medical advice is blunt. Just get it out instantly, by any means necessary.
Flick it, pinch it, scrape it, just remove it. But here is the profound limitation of everything we've just discussed in this section. Carrying an EpiPen, knowing to avoid beta blockers, knowing how to rip out a stinger, these are all purely reactive measures.
They are.
They only manage the crisis once the poison is already inside you and the immune system is already failing. You are forcing the patient to live in a constant low-level state of hypervigilance and anxiety. What if we could actually intervene before the sting ever happens? What if we could reprogram the mast cell guards to just ignore the venom entirely?
That brings us to the most powerful transformative tool in the allergist's arsenal. Venom immunotherapy, commonly referred to as VIT.
This is the ultimate medical hack. Let's define what VIT actually is and who qualifies for it.
Venom immunotherapy is a highly structured, long-term process of medical desensitization. It is strictly recommended for adults and children who have a documented history of severe systemic reactions, the respiratory or cardiovascular collapse we discussed, and who have unequivocally proven sensitization through the skin tests or blood work.
So if you just get that large local reaction, the massive swollen arm that lasts for a few days, you don't get this treatment.
Typically, no. While a swollen arm is miserable, it is not life-threatening. VIT is an intensive, time-consuming therapy that involves injecting the patient with actual purified insect venom. There is an inherent risk to the procedure. The risk-to-benefit ratio only makes sense if the patient is trying to prevent a fatal outcome.
How do they actually administer this? You can't just give someone a massive dose of the thing they're deathly allergic to.
It is a meticulously titrated process. The clinical protocols dictate a build-up phase, followed by a maintenance phase. During the buildup, the patient is injected with microscopic, highly diluted doses of the specific venom they are allergic to.
Right.
There is a conventional protocol, which involves weekly visits to the clinic, slowly increasing the dose over weeks or months.
And the sources mention rush and ultra-rush protocols as well.
Yes. In high-risk scenarios, or if a patient cannot commit to months of weekly visits, allergists can perform rush protocols in a hospital setting. They administer multiple escalating doses in a single day or over a few days, closely monitoring the patient for anaphylaxis. The goal of all these protocols is to reach the maintenance dose.
What is the target maintenance dose? How much venom are they aiming to tolerate?
The standard maintenance dose is 100 micrograms of pure venom protein. If you recall our payload numbers from earlier, 100 micrograms is roughly equivalent to the venom of 2 entire honeybee stings or potentially dozens of wasp stings injected all at once.
That's a lot.
Once the patient reaches that level safely, they return to the clinic every 4, 6, or 8 weeks for a maintenance injection to keep the immune system trained.
The clinical mechanics of how this works is where the science truly feels like science fiction. We aren't just building up a tolerance like someone drinking caffeine. We are fundamentally rewriting the software of the immune system at the cellular level. Let's dive deep into these mechanics. How do we reprogram the body?
To understand the reprogramming, we have to look past the mast cell security guards and look at the generals of the immune system, the T cells. In an allergic individual, when venom enters the body, a specific type of general called a Th2 cell takes command.
Th2, the allergy general.
Exactly. The Th2 general assesses the venom and secretes chemical messengers called cytokines. Specifically, it releases interleukin-4 and interleukin-5. These chemical orders travel through the body and command the B cells to manufacture massive amounts of those IgE-wanted posters, and they prime the mast cells for explosive action.
The Th2 general is the one screaming, "Sound the alarm, arm the tear gas, prepare for war."
But the genius of venom immunotherapy is that by repeatedly introducing the venom in slow, controlled, escalating doses, the treatment forces the immune system to reevaluate the threat architecture. It slowly strips command away from the Th2 allergy general and hands control over to a different general, the Th1 cell.
What does the Th1 general do?
The Th1 response is typically associated with fighting off viruses and bacterial infections, not driving allergic inflammation. When Th1 takes over, it produces different messengers, like interferon gamma. This shifts the entire immune environment away from the allergic cascade. But the reprogramming goes even deeper than just swapping generals.
The peacekeepers.
Yes. The prolonged exposure to the venom during VIT forces the immune system to generate a massive, localized population of specialized T regulatory cells, specifically a subset called TREG1 cells. These are the elite peacekeepers of the immune system.
How do the peacekeepers actually stop the mast cells from detonating? Do they destroy the mast cells?
No, they silence them. The TREG1 cells secrete a highly potent suppressor chemical called interleukin-10 or IL-10. Think of IL-10 as a chemical white flag. When a venom molecule binds to a mast cell and the mast cell starts pulling the pin on its histamine granules, the TREG1 peacekeeper swoops in and bathes the mast cell in IL-10.
And what does the IL-10 do to the mast cell?
It acts as a direct inhibitor. It binds to the mast cell and physically blocks the calcium from rushing in. Without that calcium influx, the granule cannot detonate.
Wow.
The IL-10 essentially forces the mast cell to stand down, disarm the tear gas, and ignore the trigger. The mast cells are still there, the venom is there, but the biological fuse has been chemically snipped by the peacekeepers.
So we're essentially training specialized peacekeeper cells to wave a white flag using this IL-10 chemical whenever they see the venom. That is a masterpiece of biology. And there is a clinical observation mentioned in the Bonifazi paper that makes this even more fascinating. It's what we might call the histamine hack.
What's fascinating here is the antihistamine pre-treatment. This is a brilliant example of a clinical side effect revealing a deep biological pathway. During the build-up phase of VIT, patients are receiving increasing doses of venom. Naturally, many of them experience uncomfortable side effects, large localized swelling at the injection site, maybe some mild hives.
Because you are actively injecting them with the thing they are deathly allergic to.
Right. To improve patient compliance and comfort, doctors began prescribing standard oral antihistamines allergy pills to be taken a day or two before the venom injection.
Makes total sense. Block the histamines, stop the itch, make the therapy tolerable.
But when researchers analyzed the long-term data of patients who took the antihistamines versus those who didn't, they discovered something stunning. The antihistamines didn't just reduce the side effects, they actually enhanced the efficacy of the entire immunotherapy. The patients who took the allergy pills achieved immune tolerance faster and more robustly.
Wait, how does a basic allergy pill over the counter make a highly complex, multi-year T-cell reprogramming therapy work better?
It revealed that histamine is not just a one-way street. Histamine doesn't just go out and cause hives and blood pressure drops. It also acts as a feedback loop, talking back to the T-cell generals to tell them how the battle is going.
Histamine talks to the T-cells.
Yes, via specific receptors on the T-cells called H1 and H2. And here is the elegant hack. It turns out that human Th1 cells, the good, non-allergic generals we want in charge, primarily possess H1 receptors. Th2 cells, the allergic generals we want to suppress, primarily possess H2 receptors.
I am following you. The generals have different radios.
Exactly. Standard allergy pills are primarily H1 receptor blockers. By giving the patient an antihistamine, you are chemically blocking the H1 radios on the good generals while leaving the H2 radios on the bad generals open to the massive flood of histamine caused by the venom injection.
But wait, wouldn't we want the good generals radio open?
Actually, no. Histamine binding to these specific receptors often has a down-regulatory effect on that specific cell. By blocking the H1 receptor, you protect the Th1 general from being suppressed by the histamine.
Oh, I see.
It allows the Th1 general to operate at maximum capacity, producing interferon gamma and driving the immune shift, while the Th2 general gets suppressed by the histamine feedback. You are artificially tilting the entire immune system's communication network to favor the protective, tolerant response.
Let me make sure I am visualizing this correctly. By giving antihistamines first, we are basically handing those peacekeepers a megaphone while simultaneously cutting the microphone cord of the allergic Th2 general.
That is a phenomenal way to conceptualize the pharmacology. You block the noise so the immune system can focus entirely on the lesson of tolerance.
The theory sounds incredible, but does this biohacking actually hold up in the real world when someone gets stung?
To answer the question of real-world efficacy, we turn to the Dami et al. Systematic review published in 2017. A systematic review and meta-analysis is the absolute apex of the medical evidence pyramid. They didn't just conduct one trial.
Right.
The researchers scoured the global medical literature, identifying a staggering 16,950 potential studies related to venom immunotherapy.
Almost 17,000 studies. The sheer volume of data is immense.
And they applied ruthlessly strict quality filters to that mountain of data. They discarded any study with flawed methodology, small sample sizes, or poor controls. They distilled those 16,950 papers down to the absolute best, most rigorous 17 randomized controlled trials. They then aggregated the data from these trials to calculate the undeniable statistical truth about VIT.
So cut through the noise for me. What are the hard numbers? Does VIT prevent anaphylaxis?
It is overwhelmingly effective. The meta-analysis calculated the odds ratio for a patient experiencing a severe systemic reaction if they were stung after receiving VIT compared to patients who did not receive the treatment. The calculated odds ratio was 0.08.
Let's translate an odds ratio of 0.08 into real-world risk.
It means that undergoing venom immunotherapy reduces your risk of a severe, life-threatening allergic reaction by 92% compared to someone who remains untreated.
92%. That is not a marginal statistical footnote. That is a life-saving paradigm shift.
It truly is. The vast majority of patients who complete the VIT protocol and are subsequently stung by the insect they are allergic to experience either zero reaction whatsoever or a very mild, normal local reaction. The life-threatening cardiovascular and respiratory collapse is completely neutralized. The peacekeepers hold the line.
But the Dami study highlights something else that I think is deeply profound, something that often gets lost when we get bogged down in T cells and odds ratios. They measured a crucial human element, health-related quality of life, or HRQL.
This metric is vital to understanding the true impact of the disease. For untreated patients, a severe venom allergy is not just a physical threat that happens once every few years. It is a profound daily psychological burden.
If you're listening to this and you don't have a severe allergy, imagine living in a state where a simple act, a picnic with your kids, a walk in a grassy park, cutting your own hedges, could result in your death within 15 minutes. You are constantly scanning the environment, a fly buzzes near your ear, and your heart rate spikes.
The anxiety is constant.
You have to carry an EpiPen everywhere, obsessively checking its expiration date, worrying if it will get too hot in the car, wondering if your spouse will know how to inject it into your leg while you are unconscious. The emotional distress is paralyzing.
It creates a shrinking world. The Dami meta-analysis showed that VIT doesn't just cure the physical manifestation of the allergy. It radically, significantly improves the patient's psychological freedom. Knowing that your cellular software has been rewritten, that you are protected from the inside out, removes that constant low-level terror.
Patients get their lives back.
Exactly. The improvement in the standardized quality of life scores is statistically massive.
But that psychological freedom relies on permanence, which brings up the million-dollar question for anyone considering this therapy. Duration and relapse. If I commit to this, am I cured forever? Or do I have to go to the allergist and get venom injected into my arm every single month until I die?
The clinical guidelines, supported by the long-term data in the reviews, generally suggest that a standard, complete course of VIT should last between 3 to 5 years.
Okay, 3 to 5 years of maintenance shots, and then the doctor just stops giving them to you.
In the majority of standard cases, yes. If the patient has tolerated the maintenance dose perfectly, and their follow-up skin tests and blood work show a massive, sustained drop in those IgE-wanted posters, the allergist will discontinue the therapy. And the long-term follow-up studies are incredibly encouraging.
What do they show?
They have tracked patients for up to 7 years after completely stopping the immunotherapy, and 85 to 90% of those patients remain fully protected against severe reactions.
85 to 90%. So for the vast majority of people, a 3 to 5 year investment of time yields decades and quite possibly a lifetime of protection. The immune system's memory has been permanently altered. The peacekeepers set up a permanent base.
That is the goal. However, medicine is never absolute. There is a documented 10 to 15% relapse rate, where patients eventually lose that tolerance and become allergic again. And the sources are very clear on identifying who is most likely to fall into that relapse category. Interestingly, patients who are allergic to honeybee venom have a significantly higher rate of relapse than those allergic to wasp venom.
Why would the bee allergy be harder to cure permanently than the wasp allergy?
It likely goes straight back to the fundamental biology we discussed at the very beginning,
the
venom payload. A honeybee delivers a massive 50 to 140 micrograms of complex, tissue-destroying toxins in a single strike. A wasp delivers maybe 5 or 10 micrograms.
Right.
It's a much harder, much more demanding immunological challenge for the peacekeeper cells to sustain a chemical ceasefire against a massive bomb than against a tiny surgical strike. The sheer volume of the bee venom can overwhelm the generated tolerance over time.
That makes perfect biological sense. The immune system just can't hold back that much poison forever without refresher training. Who else is at high risk of relapsing?
Patients who experienced extremely severe, near-fatal cardiovascular reactions before they ever started the treatment. If your baseline immune response is extraordinarily violent, it is harder to tame permanently. And circling back to our hidden diagnostic traps, patients who have diagnosed mastocytosis or elevated baseline serum tryptase levels.
The patients with the massive hidden army of overzealous security guards.
Yes. For those specific high-risk patients, the allergist will very often recommend lifelong venom immunotherapy. The risk of stopping the maintenance shots is simply too high. If their peacekeepers fade and that massive mast cell army detonates again, they likely will not survive the resulting shock. They need the constant chemical reminders.
So VIT is a modern medical marvel, but it has its limitations. It requires years of commitment. It carries a small but real risk of triggering anaphylaxis during the buildup phase since you're using real venom, and it has a relapse rate for severe cases, which makes me wonder, what does the future look like? If we project forward 10 or 20 years, how does this treatment evolve? Where is the cutting edge?
The future of immunotherapy is moving away from the messy reality of nature and entirely into the realm of precise molecular biology. The first major advancement on the horizon is the use of recombinant venom allergens.
Break down recombinant for me. What does that mean compared to what they use now?
Right now, commercial venom extracts used in clinics are natural. Pharmaceutical companies literally have facilities where they milk the venom from millions of live bees and wasps.
That sounds like a crazy job.
It is. They purify it, but natural venom is inherently messy. It contains trace contaminants from the insect's body. The concentrations of the different proteins fluctuate based on the season or the diet of the bug, and it contains all the components, even the ones the patient might not be allergic to. This messiness can cause unpredictable side effects during the therapy.
It's a shotgun approach.
Precisely. Recombinant allergens, however, are synthetic. Scientists isolate the exact genetic sequence for a single venom protein, say a phospholipase A2, and insert that gene into bacteria or yeast in a lab. The bacteria act as microscopic factories, churning out perfectly pure, identical copies of just that one specific venom protein with absolutely zero trace contaminant.
So it's perfectly clean and perfectly dosed every single time.
Yes, and it enables true precision medicine. If an allergist runs advanced blood work and finds that a patient is only allergic to the melittin peptide, but completely ignores the phospholipase, the doctor can prescribe a customized immunotherapy using only recombinant melittin.
Wow.
The patient isn't exposed to the rest of the toxic cocktail, which drastically reduces the side effects and makes the buildup phase much safer and faster.
That is amazing. We are reverse engineering the weapon to make a perfectly clean shield. But the Dami paper hints at an avenue of research that is even wilder. Skipping the venom protein entirely.
DNA vaccines. This is the absolute frontier of immunological research. Instead of injecting the patient with any form of the venom protein, natural or synthetic, scientists are developing techniques to inject a DNA plasmid.
I want to make sure I understand how a plasmid works in this context.
Think of a plasmid as a tiny, circular, encrypted USB drive containing genetic code. Scientists write the DNA sequence that provides the exact instructions for building the venom allergen. They inject this microscopic USB drive into the patient's muscle tissue.
So there is no actual venom in the needle, just the blueprint for the venom.
Exactly. The patient's own muscle cells and localized immune cells take up the plasmid. The cells read the DNA code and they begin to manufacture tiny, harmless, highly controlled amounts of the venom protein internally.
Wait, the patient's own body becomes the venom factory? Why is that safer than just injecting the venom?
Because of how the immune system perceives threats based on where they come from. When you inject raw venom from the outside, it circulates freely in the blood, where it can easily crash into the IgE-wanted posters on the mast cells, trigger the tear gas, and cause anaphylaxis. It's dangerous.
Right, that's why the current buildup phase has to be so slow.
But when the host's own cells manufacture the protein internally using the DNA plasmid, they process it differently. They break the protein down and present it on the outside of the cell on special display structures called MHC molecules.
Okay.
This specific method of internal presentation completely bypasses the mast cells and the IgE antibodies. It doesn't trigger the allergic cascade at all. Instead, it speaks directly to the T cells and naturally heavily favors the rapid generation of those Th1 protective generals and the Treg1 peacekeepers.
It's essentially sending an encrypted software update directly to the immune system's command center, completely bypassing the explosive hardware on the front lines.
That is a brilliant analogy. The software update programs the peacekeepers without ever risking a detonation. In animal models, DNA vaccination against venom has demonstrated the ability to induce deep, lasting immune tolerance safely and in a fraction of the time of traditional VIT.
That is breathtaking. It feels like we are on the precipice of mastering the immune code entirely. Which brings us to the end of our journey today. Let's pull all of these threads together.
It's been a long journey.
It really has. We have traveled from the microscopic stinger of a yellow jacket, decoding the diabolical chemical cocktails of phospholipase scissors and hyaluronidase spreading factors designed to melt human connective tissue. We've explored the body's internal battlefield, understanding how mast cell security guards operate and how hidden conditions like mastocytosis and elevated tryptase act as silent multipliers of chaos.
We walk through the painstaking deductive detective work required when diagnostic tests lie, sorting out cross-reactivity from true double sensitization using the RAST inhibition sponge, and noting the extreme controlled measure of the live sting challenge to prove a cure.
We looked at the critical time-sensitive frontline defense. Why epinephrine must be used immediately to force hemodynamic recovery, why antihistamines are useless for shock, and why beta blockers create a nightmare chemical blockade that requires the backdoor key of glucagon. And finally, we unpack the sheer marvel of venom immunotherapy, how we can biohack the T cells, use antihistamine pills as a megaphone for tolerance, and permanently rewrite the body's software to ignore the threat.
It is a profound testament to the intricate, adaptable, and ultimately programmable nature of the human body.
To you, the listener, I hope this deep dive has provided those aha moments we promised. This knowledge is a perfect example of why immunology is so endlessly fascinating. It takes something primal, the deep, instinctual, very valid fear of a painful insect sting, and transforms it. It replaces fear with an awe-inspiring appreciation for medical science's ability to fundamentally hack our own biology. It turns panic into understanding.
And if I may leave you with one final provocative thought built upon the foundational research we've discussed today, let's return to where we started. The paradox of the beekeepers. We know from the literature that extreme high-frequency exposure, getting stung 200 times a year, naturally induces the exact same deep immune tolerance that clinical 5-year venom immunotherapy achieves.
The beekeeper immunity shield.
Yes. Now project those future technologies we just discussed. Imagine a future where those DNA vaccines become cheap, perfectly safe, painless, and easily deployable via a simple muscle injection. Could we see a future where high-risk professions, landscapers, roofers, agricultural workers, park rangers are preemptively vaccinated against venom?
Wow. Instead of waiting for a landscaper to accidentally hit a yellow jacket nest, go into anaphylactic shock, almost die, and then start a 5-year reactive treatment, we just give them the software update on their first day of work.
Exactly. Or take it a step further. Could we deploy this to general populations living in high wasp or fire ant endemic areas? Could we artificially engineer that beekeeper immunity across society at large? If we can safely program the immune system's peacekeepers to ignore the venom before the first sting ever happens in childhood, we could effectively render the entire concept of a fatal insect allergy a relic of medical history.
The idea that we could intentionally design a population that simply doesn't react to venom anymore, suddenly that murky, terrifying landscape of the immune system doesn't look like a minefield. It looks like a canvas. It looks like something we can map, understand, and eventually completely control. Thank you for joining us on this deep dive. Keep asking the hard questions, keep looking past the surface of things, and keep seeking out those moments of discovery.